All right, you guys, we are getting so close to finishing up this amazing 12-lead EKG series. The last lesson we talked about ST elevation and specifically when it relates to AMI. But we can also see ST elevation for other reasons than an MI, and it's important to recognize these. So in this lesson here, we're going to talk about our STEMI mimics. Alright, I welcome you guys back to another video lesson from ICU Advantage. For those of you who don't know me, my name is Eddie Watson, and my goal with this channel here is to try to give you guys the confidence to succeed in the ICU by taking these complex critical care subjects and making them easy to understand. I truly hope that I'm able to do just that. If I am, I do invite you to subscribe to the channel below. Make sure you hit that bell icon though, that way you never miss out when I release a new lesson. Now also, if you do enjoy these lessons and you'd be interested in getting CE credits for following along with them, then head on over to icuadvantage.com/academy and join the ICU Advantage Academy, where you can watch all these videos. You'll have access to all the notes, including the new notes that I'm currently working on updating, as well as audio-only versions of these lessons. And most importantly, you'll be able to actually earn CE credits for participating in this education. So I've got some great deals going on over there, so make sure and check that out. Now, if you would like to support the channel but really don't have a need for the CEs, or if you just want access to things like the notes, then you might also want to take a look at either the YouTube or Patreon memberships. Again, links to both of those. All that stuff is going to be down in the description below. All right, and for this lesson, you guys, please forgive me for my voice. I'm just getting over being sick here, but I wasn't able to get this lesson out last week like I wanted to, but I'm ready to get this 12-lead EKG series just about wrapped up. So while it's very important to be able to recognize and act quickly when your patient is having an MI, unfortunately our patients can also present in other ways, including having chest pain and even having ST elevation on our 12-lead EKG, and it not be caused by an MI. In fact, the majority of ST elevation that we see on our 12-lead is actually not caused by STEMI. Again, if it is a STEMI, it's important to recognize this quickly and to act as time is muscle here. Therefore, when we see ST elevation on our patient's EKG, we often react quickly to this. We also need to ensure that this is a true STEMI that we're seeing. Again, when in doubt, treat it as such, but there are a group of conditions that can produce ST elevation on EKG that are not the result of an infarction. Some of them still do require emergent or urgent intervention, but then there are some that don't require anything and actually are quote-unquote normal for our patient. We call this group of conditions our STEMI mimics because they do just that. So that's exactly what we're going to talk about in this lesson here. So before we get into talking about these different conditions, just know that in this lesson, I'm going to go quickly through each of these common STEMI mimics. In reality, several of these really warrant their own dedicated future lesson, although not necessarily a part of this 12-lead EKG series. I do have several of them on my to-do list to get to in the future, but I do encourage you to learn more about these to further your own understanding. So again, let's hit real quickly on our ST elevation. And again, I've already covered measuring ST segment and the concepts of ST depression and ST elevation in the past 4 lessons. Again, if you need a refresher, please go back and watch those. Here though, I do want to reiterate that we ideally want to compare our ST segment to our TP segment when possible. You'll see here in a bit examples of why, but there are times we can actually have depressed PR segment, which can give the appearance of ST elevation if we're using this as our reference when it's not actually present. Now again, this may not always be possible to use this TP segment, especially with patients with tachycardias, but if you can, this is what you should be using. Now, one common thing that we see when we're looking at all of these ST mimics is that the ST elevation that we're going to see with these is what we call a concave shape. So to identify this, if you draw a straight line from the J point to the top of the T wave, you'll see, like with this example here, where the ST segment is below the line. This is what we call concave. If we draw this line and the ST segment is above, like we see here, this is what we call convex, as well as we can also commonly have flat ST segments as well. If we see flat or convex, that this is most likely a STEMI. Now, if we see concave ST elevation, we still could have a STEMI, but it's more likely we have one of these STEMI mimics. But again, don't discount STEMI if that's how the patient is presenting. And so this actually leads perfectly into the next point that I'm going to make, is that remember, with each 12-lead EKG that we perform, there's a real patient associated with that EKG. Now this seems obvious, but I mention this because remember that we want to correlate what we're seeing on the 12-lead to our patient that is in front of us. Our physical assessment of the actual patient can tell us a lot, and we need to remember to take all that into consideration when we're evaluating anything going on with our patient's EKG, especially ST elevation. I'll dive a little further into this with these mimics when I talk about them. And then finally, for the beginning part here, I want to share a quick mnemonic to hopefully help you remember some of the causes of ST elevation, and that is going to be the mnemonic elevation. So to start off with the first E, that this is for electrolytes, and here we're really thinking about potassium and hyperkalemia. For the L, this is for our left bundle branch block, although we can also see the same with right bundle branch block as well. The next E is going to be for electricity, and this is to help you remember both early repolarization as well as pacemakers, specifically in patients who are being ventricularly paced. Next, for the V, this is going to be ventricular hypertrophy, pretty self-explanatory. Then for the A, this is going to be aggravation. And this is a way to help you remember irritation or inflammation of the pericardium, aka pericarditis. Now for the T, this is going to be for thrombus. And here, primarily we're talking about pulmonary embolism or PE, but this could also be a coronary thrombus. And then for I, this is going to be injury. And this could be from infarction, although cardiac contusion can also cause this. Then for the O, this is going to be the Osborne waves. And these Osborne waves, or sometimes called J waves, that they can be seen particularly in cases of severe hypothermia. And then finally for the N, this is going to be non-occlusive vasospasm. And here we have a coronary vessel that is spasming and can temporarily cut off blood flow, giving us the appearance of an obstructive occlusion, but it's really transient in nature. So I'm not going to hit on quite all of these, and I am going to cover them out of order, really to kind of help group together like concepts, but hopefully this will help you to remember all of them. All right, so let's start off first with a quick and easy one, Osborne waves or J waves. So like I said, these are usually associated with extreme causes of hypothermia, so here think temperatures less than 30 degrees Celsius. We can though also see them, although rarer, in hyperkalemia, ischemia, left ventricular hypertrophy, Takotsubo cardiomyopathy, early repolarization, Brugada's syndrome, severe myocarditis, or in some causes of acute intracranial injury. Essentially, the Osborne wave or J wave is a deflection that we can see at the J point following the QRS complex. So here's an example of Osborne waves in a case of hypothermia. Now, sometimes the Osborne waves can be subtle, like we actually see in leads 2 and 3, and if that's all we see, this can actually be more associated with less severe hypothermia. So keep this in mind that Osborne wave size is going to be proportional to the degree of hypothermia. But if we look at our precordial leads V4, V5, and V6, we can see much more obvious Osborne waves. And note that this can produce ST elevation that we see, but here we're seeing that concave shape if we draw that straight line from the J point to the top of the T wave. All right, now let's move on and talk about benign early repolarization. And this can be one of the most confusing ones to identify and differentiate from STEMI. So similar to Osborne waves, with early repol, we're actually going to see something called notch J points that really aren't as pronounced waves like we see with the Osborne waves, but you will see something kind of similar. The morphology of the concave ST segment and the lack of any reciprocal changes is going to be key with this one, although we often will see this with our anterior leads, which we would not expect to see reciprocal changes because those would be happening posteriorly. So here's an example of early repolarization. So you can see obvious ST elevation in leads V3, V4, and V5. You also note the notch J point in those leads. And then, of course, if we draw a straight line, we'll also note the concave ST elevation. Another thing that really is inherent with the name early repolarization is that the repolarization is happening sooner, and thus we can see the T wave getting closer to the QRS complex like we're seeing here. So this can be confused for an acute anterior STEMI, but with those points noted above, along with the fact that our lead 2, which we also see this pattern without any contiguous leads reflecting this, as well as no reciprocal changes in our lateral leads, that this can really help us differentiate this as early repolarization. Now, Dr. Smith at the ECG blog has really put together a formula that you can plug in values for your QTC, your R wave amplitude in V4, your QRS amplitude, so both your R wave and your S wave in V2, and measured ST elevation, and get a value that can help differentiate early repolarization from acute anterior STEMI. I'll link to his blog with the formula in the description down below, and on there he also has a link to a free app that you can use for this calculation, so just another tool in your toolkit. Alright, so before moving on and talking about the next few pathologies, it's really helpful to have an understanding of a concept that we call the rule of appropriate T-wave discordance. So you're probably thinking, what the heck is he talking about? So in cases where we have abnormal depolarization, we're often going to see abnormal repolarization. So what this means is that we'd expect to see the T wave going in the opposite direction of the predominant either R wave or S wave. So if our predominant wave is positive, we'd expect to see a negative T wave and vice versa. Along with that, the J point is often going to get dragged in the direction of this T wave, giving us the impression of either ST depression or ST elevation. So as you can see here, we have an example of a bundle branch block. But in the first example, the S wave is actually our predominant negative deflection, and thus due to the rule of appropriate T wave discordance, we see the T wave going the opposite direction, which is positive, which then drags this J point up and produces a ST segment elevation. Now, in the other example we have here, the positive R wave is the predominant wave, and thus the appropriate T wave discordance would be the negative T wave that we see here, again dragging this J point down and giving us ST depression. So knowing this appropriate T wave discordance, if we had this predominantly positive R wave and we saw ST elevation, that this would actually be concerning here for an MI. And of course, patients who do have these depolarization abnormalities can still have MIs, and this can actually make this more difficult to recognize. But we do have a rule that we call Scarboza's criteria that we can use to identify abnormal ST elevation in these cases, which I'm actually going to cover in the next and last lesson of the series. Alright, so moving right along, let's talk about left ventricular hypertrophy. So I did already discuss the basics of this in a previous lesson, which I'll link to up above. But with left ventricular hypertrophy, we have an enlarged and/or thickened left ventricle, giving us the high voltage we see on EKG. Along with that, as things progress, we can begin to see depolarization abnormalities arise, which can lead to something that we call the strain pattern. This strain pattern results in T-wave discordance, and thus we can see associated ST depression and ST elevation. So in this example here, you can definitely see the high voltage in many of these precordial leads based on the massive size of the QRS complexes. We can also see T-wave discordance, especially with V1, V2, and V3 here, where we have the predominantly negative S wave, and thus the positive T wave and associated ST elevation, as well as in V5 and V6, where we have the predominantly positive R wave with the negative T wave and thus ST depression. Now with this ST elevation that we see, again, if we draw our line, we see that we have the concave shape. Now moving on to our bundle branch blocks. Again, I already covered these already as well, so I'm going to link to that lesson too. But by their very nature, these are depolarization abnormalities, and with such, we'd expect to see our T-wave discordance. So in another example here we particularly have a left bundle branch block, which we can tell with the wide QRS complexes and the negatively predominant S wave in V1. Again, in V1 through V3, we see the T-wave discordance with the associated ST elevation. And while harder to see in our lateral leads V5 and V6, if we actually look at our high lateral leads, 1 and AVL, we definitely see a dominant positive R wave with negative T wave discordance, and thus ST depression here. Again, we see the same concave shape to our ST elevation here, and then given that we see ST elevation in our anterior septal leads, we wouldn't expect to see reciprocal changes in high lateral, and thus this appears to be normal changes seen with bundle branch blocks. And this morphology and presentation is also going to be the same that we expect to see with our ventricularly paced rhythm, with the exception being that we would also see pacer spikes preceding the QRS complex. Alright, next we're going to talk about our pulmonary embolism, or PEs. And particularly massive PEs can lead to ST elevation changes on our 12-lead EKG. So let me go ahead and put up an example on screen while we talk about this one. So in this example here, we actually see ST elevation in V1, V2, V3, and V4, as well as AVR and AVF. Now this would actually be an odd pattern when we think about our contiguous leads. Another big thing to note here is that we have opposite T-wave progression in our precordial leads. Here we have positive waves in our right precordial leads, specifically V1 and V2, and then we actually have negative waves in our left precordial leads, V4, V5, and V6, which is going to be opposite of what we'd expect. Also, if you look at lead 1, this is normally positive, that here we have a large negative S wave. And so I did cover cardiac access in a previous lesson. Again, I'll link to that. But looking at this, we conclude that we have a rightward axis. This is important as a STEMI is not going to cause a rightward shift in the axis. The two main things that would produce a right axis deviation and ST elevation would be hyperkalemia and acute pulmonary hypertension. Think PE here. So now I will cover hyperkalemia in just a minute here, but we don't have peak T waves, so after correlating with our patient's signs and symptoms, we can conclude that this is probably from a PE, and then we can use further tools like a CT or an echo to identify this. Now this EKG and the tracing that we're getting isn't the greatest example, especially when we're looking at our ST segment morphology, but you can kind of see in V2 as well as V4 that concave ST segment shape. Alright, so on to the next one. We just mentioned this, so let's go ahead and talk about hyperkalemia now. So hyperkalemia can produce ST elevation that can mimic STEMI. So in our example here, we can see clear ST elevation in leads V1, V2, and V3. So is this an anterior septo-STEMI? Well, hopefully the T waves stand out for you here. And in many of the leads, we see these large, narrow peak T waves, especially V2, V3, and V4. And this is going to be classic hyperkalemia, and thus the ST elevation was actually a result of this. And also note that we do still have that concave ST elevation. And then as a quick example of a more extreme hyperkalemia here, we actually see widening of our QRS complexes, as well as we have what appears to be right axis deviation, especially when we see that large negative S wave in lead 1. Now we did just talk about this with PE, but in this example we do have our classic tall, narrow peak T waves in V2, V3, and V4. And so that's how we can differentiate the hyperkalemia from our PE here. Alright, and then finally for the last of our STEMI mimics, we're going to talk about probably the hardest one sometimes to differentiate from STEMI, and that's going to be pericarditis. Oftentimes, pericarditis is actually misdiagnosed as STEMI, as well as STEMI being misdiagnosed as pericarditis. Now, the discussion of pericarditis definitely warrants its own future lesson, but essentially here we have inflammation and irritation of the pericardial sac that's surrounding the heart. So pericarditis can actually lead to profound ST elevation across our EKG, and in later stages T-wave inversion, which can complicate this diagnosis. So how do we differentiate between pericarditis and STEMI? Well, a lot of times you're going to see the ST elevation across the EKG, and you might be thinking pericarditis, but the very first thing we need to do is actually look for some specific STEMI inclusion criteria. So first we want to do is we want to ignore V1 and AVR, and then we want to look at the rest of the EKG for any ST depression. If it's present, we have a STEMI. Next, if we have ST elevation that's present in leads 2 and 3, If the ST elevation is greater in lead 3 compared to lead 2, then again, we have a STEMI. And then next, we want to look at the morphology of the ST elevation. If we have convex or flat ST elevation, we have a STEMI. And then finally, if we have on our EKG any known acutely new Q waves, again, we have a STEMI. Be careful with this one though, as we need to make sure that they are new and acute. Now, once we've excluded any of the above cases, we can actually start to look for any signs of pericarditis. And remember to listen to the patient and the signs and symptoms that they're presenting with, as these things such as friction rub or chest pain that's relieved by leaning forward is really going to help you to differentiate pericarditis. With pericarditis, we're typically going to see a concave ST elevation globally across the EKG. So here we're seeing ST elevation going across reciprocal leads where we wouldn't normally see all this ST elevation. We can also see PR depression with pericarditis in multiple leads. Now this can be an indicator as well, although it is more associated with viral pericarditis. And that being said, patients with STEMIs still can have PR depression sometimes, so this doesn't necessarily mean you're having pericarditis if you see this. Now, along the lines with PR depression, we also can see something that we call a SPOTIC sign, which is a downsloping, almost stepwise decreasing in amplitude or height of our ST segment, TP segment, and PR segments. All right, so let's take a look at an EKG here. So on this EKG, you can see we've got ST elevation all over the place. But before we start considering pericarditis, we need to look for any of those STEMI inclusion criteria. So we want to start off looking for ST depression, which we do see it in AVR and V1, but those are leads that we can expect to see it sometimes. And so, like I said, we need to ignore those. Looking around the rest of the EKG, we actually don't see any other ST depression here. All right, so next, do we have ST elevation in lead 3 that's greater than lead 2? Well, no, we actually don't have any in lead 3, so that excludes that. Now looking at our ST elevation, do we see any flat or convex ST elevation? Nope, they're all concave. If we draw the line, we can see that clearly here. And then here we don't have any Q waves, so we're not going to do that, nor do we have a previous EKG to compare to here. All right, so now looking at the rest of the EKG, like I said, we clearly see the ST elevation across multiple leads and spanning across reciprocal changes. We see it in 1, 2, AVL, V2, V3, V4, V5, and V6. And again, it's all concave shaped. Then do we see any PR depression? Well, yeah, actually in leads 1 and lead 2, and it's hard to tell, but possibly in AVF as well. And then also maybe in V2, V3, and V4. Now in this example, it's not as obvious, but we do have the SPOTIC sign with the downsloping ST, TP, PR segments, especially when we're looking at our precordial leads. You can see that downward slope, so that starting high and then coming down lower as we work our way from the ST segment to the PR segment. And so with all of this that we just discussed and that we see here, we can conclude that we're probably looking at a case of pericarditis. And then lastly, I want to put up one more example EKG just to show you a really great example of this SPOTIC sign. I'm not going to go through all the steps here, but hopefully you can see it's pretty clear. We've got ST elevation all over the place here. And in several leads, we can really see our SPOTIC sign. But especially if we look at leads 2, 3, and AVF, we have a very clear downsloping or stepwise drop from ST to TP to PR segments. All right, well, we covered a lot of different pathologies and morphologies in this lesson, all of which can produce ST elevation and thus mimic our STEMI on EKG. It's important to be able to recognize these and to be able to differentiate them from an acute MI, as we want to make sure we can diagnose a STEMI accurately and promptly, but also to prevent misdiagnosis as well. So I hope that you guys found this information useful. If you did, please leave me a like on the video down below. It really helps YouTube know to show this video to other people out there, as well as leave me a comment down below. I love reading the comments that you guys leave, and I try to respond to as many people as I can. Make sure you subscribe to this channel if you haven't already. And a special shout out to the awesome YouTube and Patreon members out there. The support that you're willing to show me and this channel is truly appreciated, so thank you guys so very much. If you'd be interested in showing additional support for this channel, you can find links to both the YouTube YouTube and Patreon membership down below. Head on over there and check out some of the perks that you guys get for doing just that, as well as check out some of the links to other nursing gear, as well as some awesome t-shirt designs I have down there as well. Make sure you guys stay tuned for the next lesson that I release. Otherwise, in the meantime, here's a couple awesome lessons I'm going to link to right here. As always, thank you guys so much for watching. Have a great day.